Hello, everyone. I'm very glad that you join us our webinar, what we perform with ESSO. This is the cycle of webinar about sarcoma. Today, our topic is abdomen wall sarcoma. We have two great speakers, Professor Bonvalon, Professor Hohenberger, and great moderator, Professor Rutkowski. So I think it's good time to start. So Professor Rutkowski, please start.
So good afternoon. My name is Piotr Rutkowski. I represent Maria Skłodowska-Curie National Research Institute of Oncology in Warsaw, Poland. It is, as has been mentioned by Jacek, it is one of the webinars on sarcomas. I hope that we'll prove that we have great speakers and moderator as we were introduced at the end of the webinar. The topic is fascinating because it's not so often to discuss separately abdominal wall sarcomas. Usually there are analyzed in many series of patients together with extremity sarcomas, but there are some differences. So we start from the talk of Peter Hohenberger from University of Heidelberg, Germany, about the global strategy from biopsy to neo or adjuvant treatments. And thereafter, Professor Sylvie Bonvalot from Institut Curie, Paris, France, will talk about abdominal wall resection techniques. And I think that it is, we'll discuss at the end all these fascinating topics. And of course, I would invite you to ask the questions on the chat. So Peter, we'll start from your talk about the strategy.
Yeah. Dear Piotr, dear Jacek, hello Sylvie, hello to everybody listening to us. I will try to introduce you a bit to the problem and the global strategy from biopsy to neoadjuvant or adjuvant treatment in abdominal wall sarcomas. Here are my disclosures. I don't have anything to disclose with respect to this presentation. It's clearly sarcoma is not an organ cancer, and the WHO currently separates multiple, up to more than 60 different sarcoma entities. They can all appear all over the body, and it is pretty tricky first to find out which one it is and how to treat it. So the sarcomas have sometimes nice names, which do not mean so much. And synovial sarcoma does not arise from the synovia. Liposarcomas arise in the lipid contents of the body. That's true, but fibrosarcoma is nothing that arises from fibrous tissues alone, but from pluripotent stem cells. Sarcoma is an age-dependent disease. They're clearly young adults and children, but the older the people grow and the older the people get, the more sarcomas they have. It's a bit similar to pancreatic cancer. There are a few myths in sarcomas. Sarcomas should not be biopsied. It's something to be repetitively heard, even by colleagues. And sarcomas should have a capsule which along it can be enucleated. Think about sarcoma is a malignancy. I do not remember any malignancy that has a capsule, neither breast nor stomach, nor esophageal. So also sarcomas don't have a capsule. The fact that amputation in the extremity sarcomas prevents distant metastasis is also a myth. Distribution of sarcoma cells, it's much earlier than we realize that. And unplanned excision of soft tissue sarcoma results in increased rates of local recurrences. And thus the British sarcoma group a couple of years ago sent out golf balls to all those surgeons saying, if the lump you want to treat is bigger than a golf ball and growing, think about sarcoma and do biopsy first. So a few examples on abdominal wall tumors. This one looks like a lipoma. This one maybe has some lipomatous aspects. It's close or through the abdominal wall. This one goes through the bone. This one has irregular boundaries. This one, where is the boundary of this lesion? So if you do an ultrasound contrast enhanced, that's the most easy one. It's also very rare. It's a vascular malformation. So next one, this is a low-grade, well-differentiated liposarcoma from the retroperitoneum to the abdominal wall. This one, due to the irregular boundaries, is a high-grade myxofibrosarcoma, needs quite different treatment than this one. This one is a malignant peripheral nerve sheath tumor in a patient with neurofibromatosis. So it's important to separate that and not to say, okay, it has to be taken out anyway. So even in this one, looking pretty easy, if you do a full abdominal pelvic imaging, you see that this is an abdominal inguinal and later turns out liposarcoma. So this one is a trocar metastasis from a previous laparoscopic surgery for ovarian cancer with some cancer cells to be distributed to the abdominal wall. And this one, okay, one can probably take it out, but if you do full imaging, which is absolutely required prior to biopsy, it turns out that there are more of those nice nodules and it's a non-Hodgkin lymphoma. So try to get rid of that oculobrachial reflex, seeing something you think that needs to be taken out and bypassing the brain, start taking it out. Try to use the normal broad pathway. What's the diagnosis? Should it really be taken out? Should I be the one to take it out? What will it involve taking it out and which risks to assess? And there's another important component beyond imaging, that's the patient's history. If you are confronted with a young female of 30 to 35 years, 1.5 years after pregnancy, or a female after cesarean section with a tumor close to that scar, think about desmoid tumor. This is desmoid tumor. This is at the lateral edge of a cesarean incision. But the mainstay of treatment, as the group by Piotr Rutkowski nicely showed out, the mainstay of treatment shifts from surgery, which often improves quality of life, to conservative treatment. So it's important to know about that. And the disease is not classified with a C for cancer. It is an activation of the Wnt pathway, and the beta-catenin at the nucleus cannot not be removed due to a mutation in exon 3. That stimulates the patient's own fibroblasts to continuously produce fibrotic tissue. And the nice part is that those tumors, if you wait long enough and have the right patient, might disappear, even if they have initially a pretty large size. This one after 5, this one after 6 years, wait and see. So watchful waiting is the first step. And that means about 30% of the patients have stable disease, 1/3 up to 30%. I personally would say it's about 10 to 12%, but okay, there is a certain subgroup that has a spontaneous regression, and only a rough 40% is initially progressive with their desmoid tumors. And the Warsaw group nicely pointed out that the long-term results after 12 years are the same, whether you start with surgery immediately or you start with watchful waiting and have to add surgery someone in the course of the disease. So There are patients, no question, this patient due to progression went on sorafenib drug treatment. It was still progressing. You have to take that out, and we personally use more human material to close the fascial defect instead of a Marlex mesh. But you see, it is important to know which type of tumor you treat. In the retroperitoneum, for example, multiple core needles should be obtained to allow for histology. The risk for needle track seeding is 0.37% in a large group of pooled data of 550 patients. The incidence of tumor seeding in bone sarcomas is negligible. So do a coaxial biopsy, or better incisional biopsy. There is a meta-analysis and a systematic review out there showing that the results of incisional biopsy are a bit better, but not significantly better than core needle biopsy. But the rate of complications is significantly lower in core needle biopsy in comparison to incisional biopsy. So, does it work on an outpatient? If a patient shows up in your ambulance, can you do the biopsy immediately? Yes, of course. Not only you can, you should. That's an analysis of almost 400 patients on an outpatient setting. 88.5% have a conclusive result from the biopsy across all histologies. So major complications, 0.8%. Aspirin, no contraindication. Apixaban, rivaroxaban, no contraindication. Medical thrombosis prophylaxis with heparins, no contraindication. Only therapeutic anticoagulation must be paused for 48 hours prior to biopsy. So if you follow this, you can further deep dive into the patient's history, now knowing what is going on. If you are confronted with an elderly male 1 to 2 years after surgery for hernia or hydrocele of the testis, ask for the pathology of the paratesticular lipoma, hopefully sent to pathology. It might turn out it was a grade 1 liposarcoma or a dedifferentiated liposarcoma. This leads in the specific and problematic field of paratesticular sarcomas involving the abdominal wall, typically at the scar area in the groin. You see it here, that's the lesion, or this one. And here you see it much better, going through the inguinal canal and starting to expand and invade to the retroperitoneum. If you have to remove that for low grade, grade 1, that's a major surgery. That is the part of the hernia net that was implanted at that time. The lipoma was taken out. It was a liposarcoma, unfortunately. And you see the remnant growing, the skin, that's the groin, and the iliac axis. And that's the remnant of the liposarcoma close to the testicle. So the next group is patients who show up and say, without a prior history, they have a slowly enlarging lump over 1, 2, 3 years. It's probably low-grade sarcoma. At least this should be the suspicion. If there is no prior history and that tumor is enlarging over 3 to 6 months, it's looking more like a high-grade sarcoma. And if the swelling is sometimes more or less, depending on the body composition, this could be one of the malformations if it's not a solid lump. So going back to that 2 sarcoma subgroups, mainly liposarcomas, there are 2 important subgroups to be separated. The one is the myxoid liposarcoma with a fused chop translocation and the typical architecture. And the other one is a dedifferentiated liposarcoma with MDM2 amplification. So let's start a bit refer to the myxoid ones. That's a typical appearance, spindle form along fascia, this in the thigh, but also in the groin or in the retroperitoneum. The important aspect is this is large and cannot be removed with adequate margins, then there is a possibility using a histology-specific dosing of radiation therapy of 36 Gray if the diagnosis is correct. The Leiden group shows the result on 72 patients with a long follow-up of 5 to 6 years, and it shows that 36 Gray in this group of patients are equivalent to the typical 54 or 60 Gray in the adjuvant setting. Why is this important? That's scar formation in radiation areas, in the leg, in the head and neck, and you probably know about those nice Sarcoma formations in irradiated tissue with only a few millimeters of skin covering that Sarcoma. If this skin only has 36 Gray, it will heal better, quicker, and more profound as this has 54, 60, or even 66 Gray. So it's lower morbidity. And in that paper from Leiden, the group of major wound complications is 6% in the extremities. If you go to the randomized study by Brian O'Sullivan in the early 2000s, that rate is for pre-op radiation 30% and for post-op radiation 15%. So that's big improvement, and therefore it's necessary to know what's going on. The other subgroup is dedifferentiated liposarcoma. This example is in the retroperitoneum. You see, there is a component of well differentiated in the PET, isn't avid to FDG, but that's the aggressive part. That's where you should take the biopsy from, not from here. But the key figure is that there is an inactivation of TP53 and an amplification of the MDM2 gene with copy number changes of CDK4. And so this is something which nowadays we are about to target with specific drugs, something that has not been possible for the last 20 to 30 years. So these patients, for example, would qualify for respective trials. Back to that high-grade sarcomas, myxofibro. The evidence and the recommendations by ESMO or in the German S3 guidelines say high-risk sarcomas, chemosensitive subtype, neoadjuvant chemotherapy may be offered or regardless of the location. And for grade 2 and 3, pre-operative or post-operative radiotherapy should be given. So if this radiation aspect we've just discussed, pre-op has increased morbidity rates, post-op has bigger fields by 40% and higher radiation dose. So there are two options for high-grade sarcomas of the abdominal wall. The one is systemic chemotherapy with standard chemotherapy, epirubicin or doxorubicin ifosfamide, with in high-grade lesions, realistic chance of around 40% of tumor remission. And the standard treatment is better than any histological tailored chemotherapy in that randomized study from the colleagues from Milano. Or you also can use, if it is available, deep wave hyperthermia in combination with systemic chemotherapy, a study primarily pooled and driven from the Munich group, but gives you after 10 years a survival advantage in the extremity patients, but also in the non-extremity patients of those who got chemo plus hyperthermia. So knowing, grading, typing is of importance for your patients, and there must not be the reflex that lump does not belong to there and surgical removal is anyhow required. Have an adequate imaging, have a biopsy beforehand, use a qualified pathology, endowed reference pathology, think and weigh the chances and options before surgery, and think about if the biology of the disease, see the example of desmoid, and also think of combined multimodality treatments. That is important not only for abdominal sarcomas, but also abdominal wall sarcomas, but also for those of the extremities and the retroperitoneum, irrespective about the type or the location. Thank you very much for your attention.
Thank you, Peter. So we are going directly to Sylvie talk and we'll have a discussion.
Can you share my screen?
Yes, yes.
Yes, we can see it.
So we will discuss of abdominal wall resection technique. So first, I recall what said Peter just before. When you have an abdominal wall mass, it may be a non-tumor lesion like an hematoma or a myositis or a nodular fasciitis. It may be tumors, but it may be a benign proliferation like endometriosis. It may be a metastasis, and Peter gave an example. It may be a desmoid or a sarcoma. And obviously, the treatment will absolutely not be the same. And as said before, it's very important to have a good imaging with MRI and to have a percutaneous preoperative biopsy to adapt correctly the strategy. And I recall what said Peter. In case the diagnosis on the biopsy is a desmoid tumor, now with ESMO guidelines and NCCN guidelines, the first line strategy is wait and see, active surveillance, because more than half of the tumors stabilize or decrease spontaneously. You have an example there. The initial tumor was about 7 centimeters, and 1 year later, it is nearly completely disappeared. This is another example to show you that size is not an indication for surgery. It's more about the progression or the resistance to a medical treatment. You have a very big desmoid tumor confirmed by the French Sarcoma Group review. And you see that 7 years later, you have nearly nothing left. So it's very important to have from the beginning a good diagnosis with a pathologist specialized in soft tissue tumors to adapt the correct strategy. So now we will discuss of technique in case it is a sarcoma and that it is decided to resect this sarcoma, or because it is a progressive desmoid after active surveillance when it is indicated. So now I consider that it is an indication for resection. So the first type of sarcoma, it is when it is superficial, outside the superficial fascia. This is an example on the left. It is an epithelioid sclerosing fibrosarcoma. And here, the surgery is rather easy. You remove in block the tumor with free margin laterally and with the fascia, the superficial fascia, to have clear margin deeply. So it is rather easy. You resect the skin, the dermis, and the superficial fascia with a primary closure. Then you have the tumor which are only in the muscle without extension on the dermis. In such case, the skin is preserved and is detached from the anterior fascia, and the muscles are sectioned away from the tumor. Of course, you will adapt the margin to the subtype of the sarcoma, but it is not what we discuss here. So you need to have clear margin. For that, of course, you need to have the diagnosis because, of course, we discuss of a sarcoma. You have an example on the right. And when the tumor is resected with the muscle, it's very important that the mesh is fixed on the posterior side of the remaining muscles, not side to the muscles, because if you sew that the mesh side to the muscles, the pressure, which is the intra-abdominal pressure, will be responsible of eventration. So it's very important that the mesh is fixed on the posterior side of the remaining muscle. The skin is detached beyond the muscular section, and the surgical stitches are transfixing the muscle. So the skin is detached, and the surgical stitches are transfixing the muscles. Of course, if the tumor is close to the bone, you don't have muscle to fix the mesh. So the mesh may be fixed on the ribs, on the pubis, on the iliac crest, or on the Cooper ligaments. And it may be done by orthopedic microplates or transbony stitches with a drill. So this is an example, my first example. This is, it was a progressive desmoid, very painful with a compression of the vessel. So we decide to operate the patient in the multidisciplinary tumor board. And of course, because the tumor is on the bone, you have no tissue to fix the mesh, and you are obliged in such case to use microplates to fix the mesh, and laterally, the mesh is fixed on the posterior side of the muscle. Here you have the final results a few months later. Excuse me. This is an example, another example of a solitary fibrous tumor involving the rectus abdominis muscles. Again, you resect the muscle, and the lower part of the mesh is like an hammock in front of the iliac vessels. The middle part of the mesh is fixed on the iliac crest with transbony stitches, and internally on the Cooper ligament, and the upper part of the mesh is fixed, as said before, on the posterior side of the remnant tumor. Here you have the final result a few months later. This is another example. It was a myxofibrosarcoma, and again, the mesh was fixed on iliac crest by transbony stitches, and you have the final result here. Then you have the possibility to have an involvement of the crural arch, and very often the end of the oblique muscle. This is an example. Here it is a well-differentiated liposarcoma on a psoas muscle, but it is extending across the crural arch, as you can see here. And of course, you are obliged to cut the crural arch to have a one-block resection. And then, most of the time, you are obliged to resect the end of the oblique muscle. And then, for the reconstruction, you are obliged to put a mesh. You don't have your crural arch to fix this mesh, so you are obliged to fix it internally on the Cooper ligament, externally on the iliac crest with transbony stitches, and then you do the suture of the crural arch on the mesh. If the skin is very thin, you may be obliged to put an amatoplasty in front of the mesh to separate the mesh from the skin. So this is an example. If here you had a very progressive desmoid infiltrating the rectus abdominis muscle and the crural arch. So you do the resection, and at the end, you don't have anymore the crural arch, so you are obliged to fix the mesh with plates on the pubis, transbony stitches on the iliac crest, and because the skin was very thin, you put an odontoplasty in front of the mesh to separate this mesh from the skin and avoid infection. So this is the final result. You see the mesh, you see the amentum, which separates the mesh from the skin, and this is the final the clinical result a few months later. Then another possibility is that you have an intramuscular tumor, but you have an extension on the dermis. And here, of course, if you have an extension of the dermis, you are obliged to do a full wall resection. And then after you have an example here, it was after a whoop surgery of an indifferentiated sarcoma. You have an involvement of the skin, involvement of the muscle. So here, after the resection, you have two possibilities. You put the mesh, as said before, you fix it on the posterior side of the remnant muscle, but this mesh, you are obliged to cover it. So you have two possibilities. First is to use a pediculated rectus abdominis muscle. The advantage of that, it is simple because it is a pediculated flap. The disadvantage, it is that you have the resection of the muscle on a side and you have the flap on the other side. So because of the technique, you have a weakness of the abdominal wall because both sides of the abdominal wall are operated. But it is simple, and for instance, this patient had diabetes, and it was, of course, a simple technique compared to free flaps. This is another example. Here it is a very young female. It was an MPNST involving the muscle and the skin. So you are obliged, as said before, to do a full wall resection. But because she was young and that we didn't want to have a weakness of the abdomen, we put a free flap on the epigastric vessels, which covers the mesh, and you have here the final result. And of course, the advantage of this technique, it is that the abdominal wall at the end is less weak than after pediculated flap. This is another example. You have a full wall tumor involving the muscle and the skin, and there you are obliged, of course, you have the biopsy. You are obliged to do a full wall resection. At the end, you have the small intestine, which is exposed in the scar. And here we decide, because it was a young guy, to put a free flap, which was anastomosed on the epigastric vessels. And then you may have recurrence or whoops surgery with residual macroscopic disease after unplanned surgery. And of course, in such situation, it is difficult because most of the time you have an involvement of the skin and the muscles. For instance, here, it was a young female who had a whoop surgery of a leiomyosarcoma of oblique muscles. So we did a first resection with a pediculated flap. But in fact, you know, when you do resection, you never know exactly how much margin you are obliged to take. And here we had very quickly a recurrence in the fat of the flap, and reoperation was done with we cover the mesh with a dorsal free flap. So to use free flap is a possibility after whoop surgery and the first use of a pediculated flap. This is another example. It was an undifferentiated pleomorphic sarcoma of oblique muscles with a whoop surgery, then you are obliged to resect the skin which is involved by the fragmentation of the tumor. Here it is again a full wall resection, and in this case we put a mesh, as said before, fixed on the posterior side of the remnant muscle, and it was covered by a pediculated flap of rectus abdominis muscle. And here you have the final result. So to conclude, it's absolutely necessary to have a percutaneous biopsy to confirm the diagnosis before surgery, because this surgery is large and you need reconstruction most of the time. Of course, the strategy must be discussed in the multidisciplinary tumor board after a good MRI to have a very good analysis of the extent of the tumor. It's necessary in case of sarcoma to have free margin. I will not discuss how much it depends of the subtype of the sarcoma. And it's very important to have a good collaboration with the plastic surgeon in the team. Thank you very much.
Thank you very much, Sylvie and Peter. So we had few questions. Of course, Peter did the homework and everything responded on chat, but I think that it's nice to discuss it, especially should the biopsy be taken before the MRI? Of course, the answer is that we should start from the imaging because to select the correct location, as Peter told, but also sometimes when we are doing the biopsy, you can have a small hematoma inside of the tumor. So it changed also the imaging. So this is important also from this part. But this is ideal world, and sometimes, of course, if you have very fast growing huge tumor, which is heterogeneous inside, and the patient is coming to you with CT, so sometimes personally, I'm doing the biopsy and sending the patient to MRI. So because I do not want to waste the time, but of course, the ideal situation should be the MRI and the biopsy. Sylvie or Peter, any comments?
No, I fully agree with Peter and with you. It's absolutely necessary to discuss with a good MRI to have a good appreciation of the extent in the muscle, in the skin. Sometimes you may have an involvement of the digestive tract, so it's very important to have a good analysis. Then it's absolutely necessary to have the biopsy and with the review by a specialized pathologist to discuss the right strategy, because as said by Peter, in some subtypes we will discuss neoadjuvant chemotherapy. In other subtypes you will discuss neoadjuvant or adjuvant radiotherapy. So it's absolutely necessary to discuss that in the multidisciplinary tumor board. And then when it is the time of the surgery, you discuss your technique according to the extent in the muscle, to the extent to the dermis, to the extent to intra-abdominal viscera. And of course, you will discuss how to cover the mesh with the plastic surgeon, because you have two possibilities: free flap, pediculated flap. And both, as I said before, have advantage and disadvantage. The advantage of free flap, it is that, as said before, the weakness of the abdominal wall is less important, but the disadvantage, it is that it is more difficult and that you need a patient in a good condition. So the technical strategy must be discussed upfront with the plastic surgeon, especially in case of the involvement of the skin.
Okay, there is also the question and here discussion about the choice of the type of mesh. Could you, because Peter responded a lot on chat, but Sylvie, could you comment this?
Yes, a few years ago, I used biologic mesh, but I was very, very disappointed because about 3 to 4 years after you put the mesh, it completely disappeared. So I stopped using biologic mesh because long-term results are not good. And now I use two faces mesh like Parietex.
What do you mean with biological mesh that is disappearing?
The mesh which are colonized by fibrosis. It's supposed to be colonized by fibrosis. And in fact, in my experience, it's the mesh disappeared after 3 to 4 years. So I stopped using this mesh.
I'm not quite sure whether we talk about the same, because we use human dermal matrix that does not disappear, that does not bulge. It is better than a Gore membrane, because the Gore membrane is bulging over time. So it is a matter of availability, but this is, for example, used for breast reconstruction for the lower breast fold in stripes. So since a couple of years, I personally would not use a Gore. That's what I mentioned in the chat. I would not use a Gore membrane in the groin for infection reasons. And particularly if you can't really completely close the groin, you will still have peritoneal fluid around the, any Gore membrane, Gore-Tex membrane, and that leads the way to infections.
Yes, I agree with you. 30 years ago, I was using Gore-Tex and I stopped because the risk of infection, I agree, is too high. However, when you put odontoplasty on the mesh, it decreases the risk of infection. But however, I stopped using Gore-Tex. But in my experience, the biologic mesh you were talking about, in my experience, after 3 to 4 years, the mesh disappeared. So personally, but it's my own opinion. Personally, I do not use anymore this mesh, because if you do an evaluation after 3, 4, or 5 years, the result is not very good. So personally, but it is my own opinion, I use Parietex, 2 faces with a smooth one and the other one which is not smooth, and I have very good results with that.
Okay. In grade 1 intramuscular liposarcoma, how aggressive should our resection be? So generally, the answer is very easy, because it's atypically pomatous tumors or well-differentiated liposarcoma on abdominal wall or extremity. Usually we should remove outside of the pseudocapsule, and usually it's enough for this type of the tumor. Completely different in retroperitoneal space, we know, because it's although it looks like well-differentiated lipo, but usually it's much more aggressive because of the anatomic location. But in the abdominal wall, it is not a problem when you are. It is planned resection outside of the pseudocapsule. Any comments?
No, obviously, the extent of the resection will depend of the subtype. And as said by Piotr, for instance, for a well-differentiated liposarcoma, an extracapsular resection should be enough. But for instance, for an epithelioid sarcoma, which is very often multifocal, not well-defined, or for a myxofibrosarcoma, arbitrary, you will take more margins than, for instance, for leiomyosarcoma. And all that is not clearly written in the recommendation, because it's very difficult retrospectively to say, I took more margin for a myxofibrosarcoma. It's very difficult retrospectively to do that, and we will never have prospective study about that. So in fact, it is the experience that make that for well-lived liposarcoma, you will do an extracapsular resection, not like a lipoma, extracapsular resection. And for disease like epithelioid sarcoma or myxofibrosarcoma or ASPS, you will take more margins.
Okay, it's another question about the desmoid tumor. Only the pain uncontrolled by analgesic is indication of surgery in desmoid tumor of the abdominal wall or something else. What is the current approach? Sylvie or Peter, who will start?
Well, if you pain is one aspect, but it's not the only one. If you have intractable pain, okay, this can be an indication for resection, but the pain comes from the compression of the tumor to the surrounding, or even by the contact to the fascia or the periosteum. This may be an indication, but it's not the only one. If this is at a tricky location, also and an elderly patient, this is also something that can be treated by radiation therapy. And a desmoid without progression is not an indication for resection alone for pain removal, to get pain relief. Pain is something subjective. People interpret that differently. So pain alone is typically not sufficient to make an indication for surgery.
For instance, in the first paper with wait-and-see for abdominal wall desmoid, the rate of surgery of this abdominal wall desmoid was 20%. 20% of a patient were operated, which is a minority. And it was a publication which was more than 10 years ago. In the recent paper or in the recent experience with abdominal wall desmoid, of course, the proportion of desmoid of the abdominal wall which are operated is less. It is around 10%, because in fact, when we say that the majority of patients have a stable disease or sometimes the response, the tumor is decreasing in size, in fact, you have some tumor which are progressive. And when they are progressive, and that the size becomes very big, you discuss first medical treatment, but you have some patients who refuse chemotherapy for a desmoid tumor, which is in fact a benign tumor. So in some case, you are obliged to discuss the surgery. And that's the reason why for this desmoid of the abdominal, you have a rate of patients who are operated, which is about 10%.
Completely agree. So the two questions about the radiotherapy. Does postoperative radiotherapy interfere with reconstructive plastic surgery and radiotherapy on top of mesh? Do you worry? Any cautious?
Absolutely, yeah.
Yes, it depends on the technique. If the mesh is covered by a flap or with the omentum, the risk to have a retraction of the mesh is very low. And in my experience, in the few patients that we have been obliged to do post-op radiotherapy on the flap or on the omentum, we didn't have a retraction of the mesh. But I must recall that radiotherapy was validated by 2 randomized studies in limbs. There is absolutely no randomized study for the abdominal wall, so the indication is just the extent of an indication which was validated of the limbs, which is not validated on the retroperitoneal sarcoma. And the difference between limbs and abdominal wall, it is that under the abdominal wall, you have the digestive tract. So in my opinion, if the surgery is with clear margins which are large, the indication of post-op radiotherapy, for instance, in grade 2, must be discussed. And in our multidisciplinary tumor board, if the margins are large and that it is a grade 2, we will try to avoid radiotherapy to avoid the morbidity on the digestive tract.
If you have a lesion requiring radiation therapy, and you know that beforehand, It might make sense to do preoperative radiation therapy because the irradiation field is smaller, the dose is lower, and afterwards you can probably take out all the irradiated tissue because it's the tumor and the immediate surrounding, and cover that by a free flap, and do not have to irradiate a plastic reconstruction. This is possible, but in this case, it would probably be better to go for neoadjuvant radiation therapy and then remove the irradiated tissue and replace it by a full, either a pedicled or a free flap, which is well nourished and has a good blood supply.
I think particularly this strategy of neoadjuvant radiotherapy is particularly useful when you have a sarcoma which is both sides of the inguinal arch, because the crural arch, because you are close to the bone and the articulation of the tite. And in such case, it's very important to avoid the articulation and to have a smaller field of radiotherapy. But in some case, you don't have, the pathologist cannot give you the right grade between 1 or 2. And in such situation, you cannot do pre-op radiotherapy because if finally it was a grade 1, you would have over-treated the patient. In some patients, you are obliged to wait for the final diagnosis of the pathologist on the grade to discuss the radiotherapy postoperatively.
I completely agree, but especially with now more sophisticated technique of radiotherapy, it's much easier to give it preoperatively, especially in such locations like abdominal wall, and to spare the intra-abdominal organs, which is usually not feasible with post-operative radiotherapy, as you said. So this is absolutely, I agree. This is also the question about pre-op chemotherapy is always indicated to test clinical response and try to guarantee free surgical margins. No, the answer is very. This is what Peter mentioned, that usually we try to individualize approach even with preoperative chemotherapy based on the risk of the distance metastasis, as nomograms exist like circulators, etc. So usually, and of course, not in all types of sarcomas. Generally, the chemo is active, so it's this is absolutely should be established on the proper diagnosis and MDT. So it's not just to test the clinical response and never guarantee free surgical margins.
There is a question about gamma secretase in desmoid tumors.
Yes.
I just want to recall that the experience is limited. It is just recent phase 3, so the experience worldwide is limited, and the main problem is ovarian dysfunction, which can be very long, and most of these desmoid tumor of the abdominal wall, it is young female, 30 years old, the median age. So it's a little bit annoying to have this long-term dysfunction of ovarian in this young female. So there is a debate about the utilization because of that, because it is young female, and in such situation, it's annoying to have a treatment with a long dysfunction of the ovarian.
I agree, and as we know in the trials, also the abdominal wall were in minority. Now we are also involved in the trial with different gamma secretase inhibitors. The drugs are very active. That's true. Of course, in some situation we have to decrease the dose because of the side effects, but generally they are very active. It seems so, but I agree that this not only the dysfunction, but probably female infertility. This is what we have absolutely discussed with our patient, and this is why we try not to do it, especially in this location when we have huge probability that even after the growth, we can have stabilization and decrease of the tumor, and this often happens in abdominal wall. In other locations, we are sometimes more aggressive, like for example, neck, where sometimes with the desmoid aggressive fibromatosis can be life-threatening, even if it's.
Mésentérique desmoïde.
Of course, this is aggressive fibromatosis. So so in this location. So it's of course we more willing to start the treatment earlier than just watch and wait, because it's also the question about follow-up interval in wait and watch policy. Sylvie, you are the number one expert in this.
Of course, it is at the beginning that you need to follow very closely the patient and to put the patient in a group, stable disease or a tumor which will regress, or the progressive one. So the standard in the international recommendation, it is to follow very closely the patient at the beginning. So we recommend the first MRI 1 month after the diagnosis. If it is stable, you will do the next one 3 months later. If it is still stable or if it's regress, you will do then each 6 months. Of course, if it is progressing, your decision will depend of the initial size. For instance, if the initial size is 2 centimeters in the abdominal wall, you can wait that the tumor is double or 3 times the initial size before using chemotherapy or surgery. But if the initial size at the diagnosis was 7 centimeters, of course, you will not wait that it is 14 centimeters to treat the patient. So it is at the beginning that you have to follow very closely the patient, and then the decision will depend on the initial size and the location of the tumor. As said by Piotr, of course, if it is an head and neck desmoid or a mesenteric desmoid, your decision to treat will be earlier than it is an abdominal wall desmoid, where you can wait until 10 centimeters before deciding chemotherapy, which is not a pleasure for young females 30 years old. So, of course, the decision to treat, and most of the time we start with neoadjuvant chemotherapy, it must be really balanced with the fact that it is young female and that finally it's a benign tumor.
It's also the last question, probably, Peter. How do you place the omentoplasty ahead of the mesh to avoid hernia incision?
Well, it's over. Think about one thing. Omentoplasty should not cross the groin to the thigh, because you open up the space for sliding small bowel loops over time. Absolutely, yeah. This is a realistic threat.
Yeah.
Typical, and you need to consider that the omentoplasty always generates fluid. So I put it typically. I use typically the left gastric. Left gastroepiploic artery for the omentum, and put it immediately on the mesh. And then I put a drain or 2 drains on the mesh for a couple of days to remove the peritoneal fluid that the omentum always produces. So I would not, you can use it to the chest, that's not a problem, but I would try to avoid, if possible, that the omentum crosses the groin to the thigh, if that answers the question.
Okay, there are still questions which appeared. The questions about, is the role of frozen biopsy of margins before closure of the abdominal wall defect? So, or 2-step probably. Reconstruction, and in case of abdominal wall full thickness resection, do you have experience in compartment separation with mesh augmentation?
I personally, to answer that last one, I do not have expertise with that.
Me too. And frozen biopsy, we do not do it.
No. Frozen biopsy to assess the quality of the margin, it is a question.
Yeah.
It's no, usually we decide the margin we will take according to the subtype, but most of the time we don't perform frozen section.
Let's say 3 times a year. There are a few indications where I do not know exactly, and so 3 times a year if you use a frozen section.
But it's very difficult to assess sometimes, and also we have the question, especially after preoperative therapy. So I agree, but it's exceptional, let's say. And one more question about desmoid. So I thought it is in desmoid tumors resection. Do you see a difference between keeping the dissection in pre-peritoneal space or entering the abdominal cavity in terms of future peritoneal recurrences?
No, most of the time, these desmoid are located to the muscle only. So in fact, the resection, if you are really obliged to decide a resection, it is a resection of the muscle only. You can keep the skin in front, but of course the peritoneum is resected with the muscle. And you are obliged to put a mesh, as said in my talk, which is fixed on the posterior side of the muscle, which are remnant muscle, or on the bone, if it is close to the bone or the pubis. But the peritoneum is resected, of course.
There is nothing there's no peritoneal recurrence like from a cancer. You do not spread tumor cells when removing a desmoid. It's a patient's own disease that will arise from the borders of the surgical field, like in former times, that stimulates neighborhood fibroblasts to behave in the same way. It's not spillage of tumor cells like in ovarian, gastric, colorectal cancer.
Absolutely. So I think that we even increase our timing, because usually we should spend 1 hour. It's more than 1 hour. So thank you personally for Sylvie and Peter, and probably Jacek would like to summarize. Thank you.
Yes, thank you for great talks. We have very good discussions, a lot of questions. I think the especially problem is the desmoid tumor. What we see, there is a lot of questions. So thank you very much for your talks, and see you in the next webinar.